evening to one and all. Today, our guest speaker is Dr. Angela Dispenzieri from Mayo Clinic, Rochester, US. She'll be speaking to us on a very, very important subject, amyloidosis, about which there is a lot of confusion, less experience, and in many people's mind, even in the experts' mind in India, no straightforward standard of care. This webinar is brought to you by Mumbai Hematology Group. It is supported by Janssen and Pharmafer, managed by Mice Ideas. I'm thankful to the team Janssen and Pharmafer for supporting us, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Angela from Mayo Clinic, all the discussants who are very eminent hematologists, and all of you for sparing your Saturday evening for the academics. Discussants today include Dr. Sharat Damodar, Clinical Director, MSMC, Senior Consultant Hematologist, Head of Hematology in the Bone Marrow Transplant at Majumdar Shah Medical Center, Narayana Health City, Bangalore. Dr. Joseph John, Professor, Department of Clinical Hematology, Hemato-Oncology, Bone Marrow Transplant at Christian Medical College, Ludhiana. Dr. Asha Shah, Consultant Hematologist at Nanavati Holy Family BSES Hospitals, Mumbai. She's a member, Executive Committee, Mumbai Hematology Group. Dr. Deepanjan Halder, Consultant Hematologist, Oncologist and BMT Physician at Jupiter Hospital, Thane, Mumbai. Dr. Afaq Ahmed Khan, Assistant Professor, Consultant, Clinical Hematology, Hemato-Oncology and Transplant Physician in Department of Clinical Hematology at SKIMS, Srinagar, JNK. And Dr. Lingaraj Nayak, he's Assistant Professor, Department of Medical Oncology at Tata Memorial Hospital, Mumbai. And now to introduce Dr. Angela Dispenzieri to you. She has been our regular faculty. She was in Mumbai when Wockhardt was launched. She spoke to us just a few months back, and now she's again with us, and I'm extremely grateful to her. We have been troubling her, and she has been always obliging us. She is a consultant in the Division of Hematology, Department of Internal Medicine at Mayo Clinic, and serves as Chair of Hematology Research. She has joint appointments in the Division of Clinical Biochemistry and Immunology, Department of Lab Medicine and Pathology, and the Department of Molecular Medicine. She holds the academic rank of Professor of Medicine, Lab Medicine, and Pathology at Mayo Clinic College of Medicine. She is recognized with the distinction of a named professorship, the Serene M. and Francis C. Durling Professorship. Before I invite her, I just want to share a small experience of ours where we've used daratumumab with Cybor-D in 5 cases. So we have 5 cases of AL amyloidosis where we've used daratumumab in combination with cyclophosphamide, bortezomib, and dexamethasone during last 2.5 years. 2 of these are newly diagnosed. This was second-line treatment. For one of them, it was the third-line treatment. All 5 had 2 or more organ involvements, including 3 had cardiac amyloidosis. 4 of these 5 achieved hematological CR, and all 5 have had significant organ responses documented objectively. All at present are on monthly daratumumab maintenance. And we are going to hear more about this particular trial, Andromeda, from Dr. Angela today. So now I invite Dr. Angela Dispenzieri to deliver her talk on amyloidosis.
Great. Well, thank you for spending your Saturday evening with me. I am going to bring up my talk and let's see. Okay, I assume you can see that well.
Yes.
All right, so my talk is amyloidosis, and the reason it's amyloidosis and not just light chain amyloidosis is that there are a number of systemic amyloidoses. These are all protein misfolding diseases, and they're characterized by, if you look at the lower right-hand corner, this ability to make these fibrils that will, under polarized light with Congo red staining, be green. They have green birefringence under EM. They're these non-branching fibrils that are 8 to 11 microns. And this is a representation on the upper right of these fibrils. But these fibrils can be built by many different proteins that have that ability, that are rich in beta-pleated sheets. And so as hematologists, we think of the immunoglobulin amyloid, which the precursor protein in the building blocks to make this amyloid is immunoglobulin, either kappa, lambda. Rarely it can include heavy chain, but there are a number of other proteins that can cause amyloid. Again, building blocks turn into this and are really not distinguishable by either EM or just light microscopy. And so that's really important when we're making the diagnosis. The next most common amyloid will be transthyretin, and we will talk about that later as well. But the focus of our talk is going to be immunoglobulin light chain amyloidosis. So again, just to remind us, the precursor protein, so here in the left column, we have the name of the amyloid, the precursor protein, and then the different organs involved. And you can't go just by phenotype, what the patient looks like to you, to really deduce what the diagnosis is with 100% certainty. And you see here, there's the AL amyloid, the light chain, there's the hereditary form of transthyretin or ATTR variant amyloid, which is an inherited mutated transthyretin, mostly nerve, autonomic nervous system. The wild type or age-related, used to be called senile amyloid, is transthyretin that's wild type, no mutation. And uptake is, it's most commonly in the heart. It can be in the soft tissues and ligaments. And then there's an assortment of other types of amyloidosis. So it's problematic. This was a survey that was taken by patients or of patients. How long did it take you to get a diagnosis of amyloidosis? And if you can see here, symptoms to diagnosis, only about 37% of patients, it took less than 6 months from their first complaints to their doctors to actually getting a diagnosis. And if we look here, you can see that 10%, it took more than 3 years. And again, 20% or so, 1 to 2 years, and so forth. And the number of doctors visited, again, a third of patients had to see 5 doctors until they got a diagnosis. And again, the diagnosing physician, a third were hematologists, 20% were cardiologists, 23% nephrologists, and an assortment of other physicians. And so there are many doors to a diagnosis of amyloidosis. It may be through the specialist door. Sometimes it's somebody who's doing the imaging or the labs. But what we have here is the symptoms. So again, it is a disease with so many different symptoms. It's hard for everybody to think about it because it's rare. But the symptoms that we have are potentially symptoms of heart failure, but these patients typically do not have low EF. They have preserved EF, but they have diastolic dysfunction, and that can stymie cardiologists not infrequently. But a patient may have proteinuria, but more often with a preserved eGFR, certainly an AL amyloidosis. Hematology, so they walk into our office and they may have what looks like an MGUS. 50% of patients will have fewer than 10% bone marrow plasma cells. So, you look at them and you say they're not anemic, their bones look good, they have MGUS, and talk to the cardiologist. I don't know why you're short of breath. So we don't get a free pass either, because we should be recognizing these atypical features when we see somebody who has what appears to be an MGUS or a smoldering myeloma, or even an active myeloma, because these things like the heart failure, the proteinuria, symptoms of malabsorption or hepatomegaly, cholestasis, GI bleeding, are all manifestations of AL amyloidosis. Orthopedists can make the diagnosis. Carpal tunnel syndrome is not infrequent in these patients. Certainly with transthyretin amyloid, spinal stenosis seems to be pretty common, but patients may have symptoms of pseudoclaudication. But they can have autonomic symptoms, lightheadedness upon standing, sort of a painful length-dependent neuropathy, dysesthesias. There are also entities, I'm talking about the systemic amyloids, but there are localized amyloids where literally there's like a mass of plasma cells that is just leaving the amyloid right there in the tissues and not necessarily spreading around through via a monoclonal protein. It's the monoclonal protein deposits directly in the urothelial tissues or in the larynx, tracheobronchial tree, etc. But again, you can diagnose it through echocardiogram, again, the diastolic dysfunction, the wall thickening, left atrial enlargement, strain, which measures the stiffness of heart, is very important. The MRI, it's interesting, there will be patients sent to us where the cardiologist, your patient sees the doctor, they're like, I'm short of breath. They're not thinking amyloid, but they order an MRI of the heart, and the radiologist makes the diagnosis because they see delayed gadolinium enhancement with wall thickening, again, increased LV mass and so forth. CT is less helpful in these patients, but in patients who have sort of a localized amyloid, can have pulmonary nodules. You might see hepatomegaly or lymphadenopathy, but those are not common. The other thing just to mention is scans that are used in Alzheimer's disease, the florbetapir, florbedapen. There's also some small molecules that are in research. These do bind to the amyloid in the brain, which is the precursor protein is A beta, which is a localized amyloid. It binds there. But if you actually put the scanner down to the rest of the body, and it's a patient with any of the systemic amyloids, those will also light up. These are very expensive reagents, and there's no FDA approval, but it is pretty cool. Then again, a laboratorian may come up with it, just see it. If there's a lot of amyloid in a tissue, they may be prompted to do a Congo red stain. But again, the pathologists are always helping us make the diagnosis if we think of it ourselves. Because if we say, I think this is amyloid, do a biopsy, then you need the pathologist to do the Congo red, see the green birefringence, and then do typing of the amyloid. So I'm going to start with a case because this is a really good example of a patient that can kind of sneak up on you. So this is a gentleman. When he presented, he was a 64-year-old man, a white man, and it seemed that he had smoldering myeloma. He was seen by his general practitioner. He had noted to have a total protein on a chemistry group. They did an SPEP, and indeed he had a sizable M spike, 2.9 grams per deciliter. His IgG was 2,900 milligrams per deciliter, and there was suppression of the IgM and the IgA. His creatinine was the upper end of normal, calcium was normal, hemoglobin was normal, beta 2, not very remarkable. Again, I guess 2 creatinine measurements, sorry about that. And then the 24-hour urine protein was a little elevated, but the M spike was 50% M spike. Bone survey was negative. He didn't have osteoporosis on the bone density. Bone marrow showed 20 to 30% kappa restricted plasma cells. And so he was called smoldering myeloma and watched. And then after about 5 years of observation, he started having some pain, sort of his lumbar back. And it was sort of like claudication, pseudo-claudication. The MRI was done, nothing you could see. We did a fat aspirate thinking, yeah, could this be amyloid? That was negative. EKG, echo, unremarkable. His troponin was elevated though. He was having trapezius pain. He was having a lot of muscular aching and sort of maybe just even a little bit of enlargement of the muscle groups at the shoulders. He had some dryness of his mouth. He was reporting because of the dryness, he was having difficulty swallowing, and he was developing a little bit of hoarseness in his voice. His EMG motor activity was even at rest, was a report from the outside. His CK was normal. EGD, ENT evaluation were unremarkable. He's using muscle relaxers, gabapentin. He had Botox injections, just trying to relax some of the muscles because he was having this sort of very stiffness. They entertain stiff man syndrome, but he did have a muscle biopsy, and indeed, he had amyloidosis, and it was AL. Back in the day in 2005, we did immunohistochemistry, was the way we typed our amyloid. His bone marrow hadn't really changed. It was 20% kappa restricted plasma cells. His M protein hadn't changed. His FISH was normal, but indeed, this is no longer smoldering myeloma. This is AL amyloidosis. Now, his presentation was really not typical. Muscular involvement is not a common presentation, but it just shows you how sneaky amyloid can be. So one always has to be thinking about it. And if you have a clinical suspicion, you do a history and physical exam. You are going to do laboratory tests, serum immunofixation. We're doing blood mass spectrometry in our lab, so I have mass fix there. Urine immunofixation, the serum immunoglobulin free light chains as a good first start. If there is a monoclonal protein present, then bone marrow biopsy, fat aspirate. And if it's positive for amyloid, well, you have to do typing. We prefer mass spectrometry to type the amyloid, and then you get your diagnosis, whatever it is, and then you can move forward. If, though, the bone marrow and fat aspirate aren't positive for amyloid, but you might have a clone there, depends on your clinical suspicion. If you have a high clinical suspicion, then you're going to do an organ biopsy. If the patient has muscle, complaints like this guy did, then we are going to do a muscle biopsy. If it's positive, again, you're going to, make that diagnosis and you're going to type the amyloid. If your index of suspicion isn't very high, then, you just kind of continue to observe. So an interesting point is if one thinks about AL as a diagnosis, you don't necessarily have to do, a heart biopsy or a kidney biopsy. Bone marrow is positive for amyloid in about Congo red positive in about 50% of all AL patients. So not a perfect test by any means, but you can sometimes get your diagnosis there. And also fat is a little more sensitive for AL. So 85% of AL patients will have a positive fat. And then either, if you do bone marrow and that, about 90% of patients will have a positive study. So yeah, 10% we're missing, but it's a pretty good start. But this is a really interesting study done by my colleague, Wockhardt, and he went back and he looked at patients who had heart, kidney, liver, and nerve biopsies, who also had, at the time of their time of their diagnosis of their amyloid, they also had either a bone marrow or fat done that happened to, was it or was it not also positive? It ends up a lot of these patients, they were seen by cardiologists or nephrologists. So, they went straight to the organ, not necessarily thinking of amyloid, and they got their diagnosis. But had they thought of the diagnosis for the cardiacs, 96 cardiac cases, 67 or 72% of them could have avoided the heart biopsy, the endomyocardial heart biopsy. Similarly, of 198 kidney biopsies, 148 of those had positive fat and or marrow. And so 3/4 could have avoided their kidney biopsy had somebody been thinking about it. And similarly for liver, 79%. And then, nerve, we didn't have that many there, and it was 2 out of 4. But again, if you think about it, you can sometimes get away with a safer type of biopsy to get your diagnosis. I can't emphasize enough the importance of typing amyloid. This is a really old study. It's almost 20 years old at this point, but it just shows the point that at the National Amyloid Center, they had 350 patients with, they did PCR screening for ATTR, ApoA1, ApoA2, fibrinogen alpha, and lysozyme variants. These are all amyloid precursor proteins among patients who look like they might have AL. And they found that 10% of patients who had a presentation that was consistent with AL actually had hereditary amyloidosis. Conversely, when they look at the hereditary patients, 24% of them had an incidental monoclonal protein. So when I first started in this business, the recipe was you have amyloid and you have a monoclonal protein, it must be AL. Well, that was good for, 30 years ago or 25 years ago, but it is not really sufficient in 2021. This is a similar exercise, just looking at patients who had endomyocardial biopsies. 30% of patients with ATTR amyloid had positive light chain and immunofixation studies. So if we look at it, the green are the AL patients, and almost all AL patients will have a positive serum or urine immunofixation or an abnormal serum free light chain ratio. So it's like 96% of patients here. Here, when we look at the ATTR patients, 30% also had a monoclonal protein. Again, a lot of these are wild type patients, and wild type amyloid ATTR patients are elderly, and elderly patients are more common to have MGUS. And so again, MGUS plus amyloid does not necessarily equal AL. And these are just sort of breaking down the various studies and how often it's positive. So how do we type the amyloid? So here is an example of Congo red stain, immunohistochemistry. In the right hands can be a good test, but often people are not, they don't have good antibodies, they're not experienced at it, and immunohistochemistry is not reliable. Immunofluorescence can work, but you need frozen tissue. Again, I would still say mass spec is better. Immune electron microscopy, it's not readily available at most centers, but that can also be helpful. But we consider laser dissection tandem mass spectrometry as the gold standard. It's not limited by an antibody panel chosen, which all these other things are. But unfortunately, it isn't available at most centers, but we have a commercial assay, and this is starting, they're using it in the UK and France and a lot of different places now, Italy. So how does this work? So this is mass spec, how we do the mass spec for typing amyloid. So here we have Congo red staining of a tissue, and literally a laser microdissection is done, and then heat-mediated antigen retrieval, trypsin digestion, and then you put it on the mass spectrometer, and then there's bioinformatics, and then we generate a protein identification report. Along with the amyloid, there are other peptides that travel with the amyloid, and we call those signature peptides. And so these are sort of like chaperones or just proteins that are commonly found in amyloid: apolipoprotein E, SAP, and apolipoprotein A4. And so here is an example of a readout that we get. So each of these labels that are labeling the sort of the rows are different peptides. Each of the columns is a separate patient, and it's put here. So there's different types of patients with different types of amyloid. And so if you read down, you see Yep, they have the signature peptides, the apoprotein E, serum amyloid P component, and APO4. Not all has all, but usually 2 out of the 3 is common. And then, depending on what type of amyloid the patient has, we're going to see that type of peptide in the amyloid. So things like apoprotein 1, here's the kappa, a lambda amyloid, a kappa amyloid. There's oodles of different types of amyloid that are out there that we can detect and have detected. So you have a diagnosis. What do we do now? So the treatment of amyloid, basically, we know we have bone marrow plasma cells. They make immunoglobulin. The light chains are circulating in the bloodstream. They misfold. They in and of themselves, they can form some oligomers, which can be toxic in and of themselves, but they also will form these amyloid deposits in the various tissues, causing organ dysfunction and, if gone unchecked, death. So since the 60s, we have been using plasma cell-directed killing in order to get rid of the bone marrow plasma cells, drop and the light chain so that you don't have any of that building block to make more amyloid. And we rely on the body to heal itself, which it actually does. So it's basically very inefficient. The body is very inefficient at getting rid of the amyloid. But if you get rid of all the building blocks and you're not putting down more and more and more, the body can slowly reabsorb that amyloid, and you can not only get hematologic response, but you get organ response. You get resolution of the proteinuria. You get reduction in the diastolic dysfunction in the heart. You can get shrinkage in the size of the heart. You get shrinkage in the size of the liver. The neuropathy improves. The tongue can sometimes improve, but not always. That's kind of a tough one. And we'll go through a lot of these therapies, but these are, drugs that we've borrowed from the myeloma world in order to treat patients with amyloid. But the other thing, doxycycline may be an inhibitor of proteotoxicity. There's a case control study showing that perhaps this may reduce the likelihood of death in patients with advanced cardiac disease, so something to consider. But the amyloid-directed therapy sort of started being looked at in the 2010s, and the anti-AL monoclonal antibodies, so the Porthina Neo-D001 was really sounding very, very exciting in the 2010s. Unfortunately, a couple of studies did not bear fruit, and that program was shut down, though it is reemerging. They think that perhaps in patients with, advanced cardiac disease, there may be a signal. So we may see that drug coming. We are going to see that drug coming back in clinical trials. But what is currently open in clinical trials is CAL-101, which is another antibody that actually binds to the amyloid itself and helps the body resorb the amyloid. So currently there are phase 3 studies, basically physician's choice, randomized with or without the monoclonal antibody. And so more to follow on that. There was anti-SAP depleters and anti-SAP antibodies that has not borne fruit. So the goals of therapy is to get a hematologic response. And what you can see here is now a study that's about 10 years old now, but we took patients from multiple institutions and we graded how deep their hematologic response was, whether it was a CR, which did not require a bone marrow, it just required normalization of the free light chain and immunofix negativity of the serum in the urine. Here you have the VGPR, which was a drop in the DFLC, or difference between the involved and uninvolved free light chain, to below 4 mg per deciliter or 40 mg per liter. And then a partial response, which was a 50% reduction in the free light chain. And then no response was not meeting any of those criteria. But you see that those patients that got a CR really did better than those getting a VGPR, and those even, better than those getting a partial response. So dropping those light chains is really important. And also in that paper, it was sort of validating that a drop in NT-proBNP, which is a cardiac biomarker, a circulating blood marker, that it sort of relates to cardiac stretch. And if that drops, then again, if it drops by 30%, then that's a good thing. If it basically is stable, that's not as good in terms of overall survival. And if it progresses, that's really a bad thing. But we do a lot with biomarkers in the blood, and this gets us to prognostic features. So we have the original Mayo 2004 system, which was really just using troponin T and NT-proBNP. And then the Europeans broke the stage 3 into those patients who had both of these abnormal, but with the super high NT-proBNP, they called those patients 3B, and then the ones that just had elevation but not super high NT-proBNP, 3A patients. Shaji Kumar from our institution did something a little different. He included the free light chain into this sort of equation. The TNT is about the same, really the rounding error here, but he used an NT-proBNP cutoff of 1800. And in doing that, again, if you have none abnormal, you're considered stage 1. If one's abnormal, stage 2. If 2 are abnormal, a stage 3, and if 3 are abnormal or above the cutoff, you're a stage 4. And so these are really powerful means by which patients can be stratified, because patients with AL are so heterogeneous. This is an equalizer to really let you know what type of patient you're speaking of. Now, we just recently did a project looking at, because here's the stage 4 patients using those cutoffs that we had talked about, and that should be DFLC 180 mg per liter. Sorry, that's a typo. But if you look here, most patients who are stage 1, or virtually all patients who are stage 1, will not have a very, very high NT-proBNP, the 8500, though there will be a small segment, about 6% of patients will have, that are stage 2, a very high, the 8500 NT-proBNP, and about 20% of the stage 3s and 44% of the stage 4s will have a very high NT-proBNP. The 8500 is basically a cutoff that's been used in clinical trials. So they are excluding anything in blue from their trials, regardless of cardiac stage. And you can see that even among the stage 3 patients, there's really a significant demarcation in the overall outcome in terms of survival amongst patients with the lower NT-proBNP and the higher NT-proBNP. And notably, even those that would be called Mayo 2012 stage 3, 61% of these patients are going to die at 12 months if they have the ultra high or the very high NT-proBNP. Similarly, the stage 4 patients who have the very high NT-proBNP, those patients do far worse than the stage 4 patients who have not as high an NT-proBNP. And again, if we look at how they do at 1 year, the percentage dead, again, 82% of the stage 4 patients who have an ultra high or a very high NT-proBNP will be dead at 1 year, which is a horribly sobering type of a thing to think about. But again, the stage 4 patients who don't have the ultra high NT-proBNP, just moderately high, survival is much better. It's about, only about 40% are dead or 60% are alive. So it's important when you look at clinical trials in terms of expectations. The other thing is just putting things together. This is also from the National Amyloid Center, where they looked at the stage 3B patients. So that's the 2004 with the European modification, just using patients who have the NT-proBNP greater than 8,500, along with a troponin that's greater than 0.035. And what you can see here is that if you can get them into a CR or a very good partial response, these patients do way better than what we would have expected. Again, we were expecting, close to an 80% death rate in these patients. If you get a partial response, that does not seem to be sufficient in these patients, though it's better than no response at all. And so highly effective plasma cell killing is very important for all patients, but very much so for the sickest patients. So moving on to the Andromeda trial. So this was just published in the New England Journal of Medicine, but I'm using some of the slides from some various meetings because they're a little prettier. But this is the trial design. And so here, the eligibility were, you have to have at least one organ involved. You couldn't have prior therapy for AL or multiple myeloma. They excluded those patients with the ultra high NT-proBNP. And they allowed patients with eGFRs up to 20 mil per minute. And then they stratified them by the stage 1, 2, and 3A, country about transplant, because there was no intent to transplant in this cohort, but there are some countries that you can't stop the investigators, the physicians from trying to put their patients onto the transplant path. And then also stratified by creatinine clearance. And the primary endpoint was overall hematologic CR, what's called major organ dysfunction, PFS, organ response rates, time to hematologic response, survival, safety. But here you are. So patients are screened, they're randomized 1-to-1, and they get standard cyclophosphamide bortezomib dex. And this is the weekly schedule of bortezomib sub-Q. And then this is not a blinded, this is an open label kind of study. So you get the CyBorD with the daratumumab according to the usual schedule, the 8 weeks of weekly, and then every other week for the next 4 months, and then every 4 weeks. And so it was 6 cycles of therapy and stop for the control arm and observe. But for the Dara arm, they continued the daratumumab with an intent for a maximum of 24 total cycles, so up to 2 years of therapy, and then observe. And so this is the primary analysis, median follow-up of 11 months. And the deeper the color is the deeper the response, essentially. So here is the DARA VCD in purple over here, and the oranges are just the plain CyBorD or VCD. And you see here the CRs are 53 versus 18%. The VGPR is 25 versus 31%. And then PRs, you can see, overall response rate 92, hematologic response rate 92 versus 77. When you look at organ response at 6 months, you can see that you have, for the DVCD, those patients who had cardiac involvement, 42% versus 22% having a response. And similarly, the renal, you have 53% versus 26% for the two arms. And so you see the odds ratios 2 and 3, really sensational types of outcomes for these patients. And so this is the paper. This is the major organ deterioration, PFS. You have here the DARA2. So major organ deterioration includes the it would include hematologic progression or time to dialysis or time to heart transplant or some kind of ventricular assist device for the patient. But you can see that the MOD PFS, again, with a hazard of 0.58, quite impressive with the daratumumab as compared to the VCD. Overall survival, so far, no signal, but really, really short follow-up. So more to come. So how do we put this into our thinking of treating patients with amyloid? So it goes without saying that dara-CyBorD is, if it's available, this is the way to go. If we look on sort of the transplant ineligible, because that's how we've sort of thought about amyloid to this point, or at least in the US, that's how we thought about it a lot, is if you're transplant ineligible, you would plan on getting dara-CyBorD after a couple of cycles. If you haven't had a response, a deep response, at least a VGPR, you really want to think about saying this person is refractory. We're not happy anymore only with a partial hematologic response. And some would argue they're not happy with even a VGPR. They want a complete response because there's work now being done even on MRD, minimal residual disease in the bone marrow. But that said, at least a VGPR, if you have this deep response, then you continue, and we would say this is basically the Andromeda trial. You complete the 6 cycles of the dara-CyBorD, and then you continue with the dara for 18 months. Now, do you really need to do 18 months of daratumumab maintenance? I can't tell you the answer to that question because we don't know. If you think about the myeloma literature and the recent presentation of the Cassiopeia study, which was dara VTD versus VTD with transplant, and then consolidation, and patients were randomized between getting dara sort of throughout versus not. What you see is that those patients in that study who got dara as induction, it didn't matter if they had additional daratumumab subsequently. Those patients did as well as patients who had gotten the dara continuously, as a maintenance, or as well as if you didn't get the maintenance, if you got the dara as part of induction, as well as those patients who just got the VTD as induction and then got their transplant and got dara as maintenance. All 3 did as well. The patients that did the worst were those who did not get any dara at all. And so that really, in the myeloma world at least, made the question arise, gee, if you get dara up front, do you really need to maintain it? But I digress a little, but it's food for thought because, this gets quite expensive. And so one needs to really consider, but we're talking, specifically as the trial is. Now, this right-hand side is really getting problematic because we used to be great fans of transplant because, you had the highest rates pretty much, 40-odd% CR rate. So it seemed like for the right patients, it was a really good option. However, if you give them induction with dara-CyBorD, a bunch of these patients are coming, for their stem cell collection and transplant, and they're already in CR. And so the question is, do you really put somebody through the risk of transplant in that circumstance? And the answer is nobody knows the answer. But more and more, if they are in CR, we are, considering maybe just kind of going down this other path here of, just using some maintenance of daratumumab as opposed, and you don't have to, you just complete the 6 cycles in Dara, and you just kind of do it like the Andromeda trial. That said, those patients who have, have amyloid, but they have 40% plasma cells. So they're kind of a little myeloma-like, or even if they have true coexistent myeloma with lytic disease and so forth, or if they have a high plasma cell burden, you might think about taking them down the transplant path a little bit more. But again, we're sort of shooting in the dark, and there's a lot that goes into making that decision. Certainly, if they don't get, a CR, then thinking about doing transplant makes a lot of sense. And again, always, if you're not in a VGPR, you really have to say that that's a failure. And some would say if you're not in a CR, you're a failure. Something else to note, in general, post-transplant, we do not tend to think of using maintenance. That said, if somebody was very myeloma-like or had really ugly looking cytogenetics, which is rare, we might think of doing some kind of maintenance, but that is not the rule. So I want to mention another randomized trial that was just published this year. And this one is bortezomib, melphalan, dex versus Mel-dex. And this is a small study, but it's also important, showing how adding bortezomib to alkylator and steroid is really important. So in this very small study, you could see that the VGPR rate, 47% versus 25%, CR rate was only 8% versus 4%, but again, deeper responses with BM-dex. And also by cardiac stage, you also had that same improvement in response rate, regardless of what the cardiac stage was. But notice 3B patients are omitted. And this also is the publication by Kastridis is the first author. And you can see that on the left, progression-free survival, BMD superior to MD, overall survival superior. Andromeda, we don't have a signal for survival yet, but that's partially because we have very short follow-up. I would anticipate we will see as much, but time will tell. So moving forward, there are a lot of treatment options for AL patients. We borrow from myeloma. And so this is just our experience that we published a few years back about just how treatments have changed over time. And what you can see here, newly diagnosed patients, transplant, pretty much we're a referral center. So, about a third of our patients have had transplant. In the early 2000s, it was mostly melphalan and prednisone that we treated. And then when the Palladini paper came out showing Mel-dex, we moved to Mel-dex, sort of no more MP, and we sort of did MD. And we were playing around with IMiDs a little bit in the early 2000s, and also single agent dex. And you see that both over time, IMiDs as induction, not so common in AL, in part because they can be cardiac toxic, in part because they really do not seem to give as deep a response as PIs. There is a little bit of literature about using, PI and IMiD and DEX, but patients, you have to be really careful because they can get kind of sick using that strategy, but it's certainly possible. But again, bortezomib has been really incorporated as time has moved on, and you can see why in the prior study. We were to do it here now, starting at 2020, for example, we're going to see a lot of daratumumab, right? But with those interventions, we have had a definite improvement in outcomes. And that is true for both those patients that we transplanted and patients that we used other therapies for. And so the different color lines are basically the red line are the patients that were diagnosed in the early 2000s. And then green is 2005 to 2009, and blue are those patients diagnosed 2010 to 2014. And you see that the most improvement really happened for the transplant patients in the more recent time period. And I think because this is overall survival, I think it's partially because we have better salvage regimens, and perhaps we've gotten better at picking patients. What's interesting here is the patients who had non-transplant therapy. You can see that the biggest change went from the 2004 group after 2005 onward, but even incorporating bortezomib as upfront therapy didn't seem to change outcomes that significantly in this cohort. Now, again, you can't compare this left curve to the right curves, because again, these patients that get transplant tend to be healthier patients. We don't take the sickest patients to transplant, and these were sicker patients. So it's there just for visualization, but again, it's not to say that transplant is, superior, because they really are different populations. And this just shows who do we take to transplant at Mayo. Physiologic age under 70, in general, we definitely have done patients 75 and 76, but they have to be young 70-year-olds. Then good performance score, good blood pressure. Transplant high-dose chemotherapy causes very significant blood pressure drops, for about a month, some kind of endothelial damage or whatever. And if you start with somebody who has a sitting blood pressure of 70 due to autonomic dysfunction, you give them chemo and they really are hypotensive. They can't get out of the bed. The troponin, and again, high sensitivity troponin is currently out there. And so I'm just showing you what that cut point is. Then creatinine clearance. We like to have good renal function and less on chronic dialysis, good New York class, and no more than 2 organs significantly involved. Again, you might put as a bullet here, patients in CR, or not in CR, it may be an eligibility too, as time evolves here. But, we really, the thing about transplant is people have been doing it for several decades now, really more than approaching 3 decades worth of transplant. So we have long follow-up on these patients. And what you can see, these patients who were transplanted and have achieved a CR, 10-year survivorship is like 75%. Now it's about 40% of patients who do get a CR. And so that's why it was a darling, because it really seemed like you could do a therapy, be done with it, for many, because CR tends to be reasonably durable, though not perfect, and really get excellent survivals. And even the VGPR patients, the median overall survival was 105 months, and partial response, you can see 74 months is the median, and patients didn't respond. A lot of them, died is why they didn't respond. And, eventually they may later respond, but their outcomes are less good. And so that's where transplant is appealing. We don't know the durability of, DARA, VCD, or even BMD for that point, or VCD. How durable is it really? When people do case controls, it seems in terms of progression-free that you get a better progression-free when you're using, a PI, alkylate, or steroid. With transplant, when you're sort of doing case match type of things. So again, just to keep in mind, stage 1 and 2 patients have a 10-year survival rate of 75 and 60% respectively with transplant. And I showed you that 10-year overall survival 75 to 80% if you get a CR with transplant. And with good selection and experience, TRM is less than 4%. So this is an important thing to think about. So there are a couple of points on this slide. One is the concept of when we talk about organ improvement, so proteinuria, for example, is a renal response, improvement in proteinuria. And, for a long time, it was a 50% reduction. Then Palladini talked about, a 30% reduction was some kind of a response. So you could tell sooner because we know it's very slow. And then NT-proBNP, a 30% reduction. But Eli Mukhtar, also again from our institution, he said, well, we grade hematologic response. Why don't we grade organ response? And does that correlate with outcome? And also, what's the time to these maximum organ responses? And so you can see here, green is if you get the, the NT-proBNP 90% reduced or, basically normal. Not that many patients, get that level of improvement, but again, it does take time to get there. You see that, at 4 years, there's still patients that haven't yet gotten to that point. When you look at a 60% reduction, again, you see, ultimately about 60% of these are all responding patients, by the way, just to clarify, he took patients with hematologic response. But these 60% of patients, almost 60% get a 60% drop in their NT-proBNP, and then the standard 30% reduction is, the majority of patients who've had hematologic response will get this. But the point is, it takes time. And this is an important, you can say the same thing for renal response and liver response. So the deeper the response, the longer time it takes based on the therapy, even though you've stopped the therapy, because again, you're getting a heme response and you can get that rather quickly, but the body has to resorb the amyloid and that takes time. And so often people are having organ response way after you've stopped your therapy if you've gotten a deep hematologic response. And so that is important, number one, because you don't want to just, if somebody's in a hematologic CR, you don't want to say, but look, they still have proteinuria. I better keep giving them chemotherapy, or let me give them more chemotherapy or different chemotherapy. No, as long as the light chains are gone, we're in good stead, and you just have to be patient and the organ will mend itself. So that's the first part. The second part is that when we look at these antibodies that are used to resorb amyloid, when you have like the phase 2 data or phase 1 data or whatever, and it says, and 30% or 40% of patients, with single agent NeoD or single agent, Calum 101, they had organ response. Well, the question is, what chemotherapy did they have before? And is it because of the antibody, or is it because they were destined to have a organ response based on their hematologic response? And so that's where these phase 3 studies are so important with these monoclonals that are helping resorb the amyloid. And again, this is just showing the depth of cardiac response also correlates with survival. Even the depth of renal response also correlates, and the depth of hepatic response correlates with overall survival. So the point here is, again, these therapeutic monoclonal antibodies, really important to be thinking about that. So relapse disease, we go back and we have the therapies. I guess I went too fast here. Let's go page up or previous. Sorry. We have a lot on our menu to kill plasma cells, and I'm just going to talk about some of them because of the sake of time. Again, in relapse refractory disease, if the patient has a heme relapse more than 2 years after therapy, you could try the original therapy. But we like daratumumab-based therapies. Obviously, now if a patient's relapsing on 2 years of Andromeda maintenance, then we have to go down different paths, right? And then, of course, if they're not bortezomib refractory, CyBorD, VD, BMD, a question that's been brought up is how valuable is the alkylator once you just have the bortezomib on board. There's retrospective data saying that possibly the alkylator doesn't add much. So again, these are questions without perfect answers. And then the IMiDs are here. They can work. I've had some patients with remarkable responses. With lenalidomide, do not start with 25 milligrams. You have to start with no higher than 15 because these patients can have cardiac toxicity and drops in blood pressure related to the medication. And then obviously, venetoclax, so carfilzomib in nerve only, but you have to really be careful with patients with cardiac and maybe even renal. So we really like Velcade, and ixazomib is another therapy that is important. Then we also have venetoclax, which I'm going to talk to you. But let's talk about our guy that I started with, the guy who snuck up on us, 5 years of smoldering myeloma, but then amyloid sneaking in. So when he was diagnosed with the amyloid, his free light chain was high, 252. And in today's world, he would be classified as active myeloma, but this is a long time ago. So he had kappa free light chain, and he got Meldex, and his light chains went from 250 down to 2. His M spike went from a 2.5 down to a half a gram. So that was considered to be, in the old parlance, it would have been hematologic PR. In the newer parlance, it would be a VGPR because his DFLC is less than 4. So he did well. So I don't have it plotted on here because we changed electronic medical records and it makes it hard, but 250 would be off the chart here. But he did well for a while. So 2007 until 2012, he did well, but then he ended up having a rise in his free light chains. It was up to 16. Not 252, but 16, his kappa free light chain. He got Meldex for 8 months. And again, it went down from 16 to, around 4. And so we watched, and then it didn't last that long. So we tried bortezomib and Dex, and he had a nice response. It went from, you can see, a little over 10 or 11 down to his kappa free light chain went to, about 2. And so then we just kind of watched him. And he's kind of a frail guy. He had a stroke kind of right around here as well, a cerebellar stroke. He started when he was 64, but now already he's gotten to be, he's in his 70s. There we just follow. He got a lot of his care in Florida as opposed to Minnesota. So he came and saw us. We'd mail him kits. There was one test result that was really high all of a sudden, and we said, well, let's just repeat that. And indeed, I don't know why it was high. His kappa also had gone, his lambda went up a little too. So maybe he was dehydrated or something, but it came down all by itself. So we were good there and we just followed. But then it really did seem to be going up and he wasn't feeling so great. So again, this is now, 11 years into his diagnosis of amyloid. He got some dexamethasone. He was very ambivalent about the Velcade and the IMiDs and all the rest. And so we just did some dexamethasone and that made a difference as well. And then here, 2018, we tried daratumumab in him. It wasn't as stunning a response as I would have expected or hoped. And so this is kind of that course. He actually died at the end of 2020, and I reached out to his wife by mail, and she didn't get back to me. So I don't know exactly what happened, but he had been on, doing sort of okay, but he was very, very frail. So daratumumab, this is kind of busy, but it's a summary from editorial I wrote on these three really important papers that were published in Blood. So daratumumab in the relapse setting, and there's all kinds of series, but these were two phase 2 studies, and then a very large retrospective from Germany looking at daratumumab with dex, and then dara bortezomib and dex. And then for kicks, what I did is I put in relapse refractory myeloma just to sort of show how different it is in patients with amyloid than it is from patients with multiple myeloma. And so again, if we look at the numbers of patients, really small numbers of patients in these studies, the Germany retrospective is nice because there are at least a few extra patients. But again, these patients, prior therapies, 2 or 3 for the majority. The trial was designed for 24 months. So the US Boston University study, 24 months. The French study was only 6 months of daratumumab. The German thing, they didn't specify because it was a sort of a retrospective thing, but patients got 14 infusions. So, kind of again, more along the 6-month period. And then various kinds of steroids used as part of it. And then you see that the free light chains, and this is mgs per liter. So the Boston group had relatively low free light chains. The French group had higher. And then Germany had, kind of somewhere in between. And none of them had really high plasma cell counts. And then just looking at how long the follow-up was for these various study. And this is Usmani. I didn't put this on the slide. I apologize. But if you look at the hematologic response for DARA with dexamethasone or steroid, the overall hematologic response in the Boston group is 90%, 70% in the French group, 64, 66% in the German group. But we all know for myeloma, it's just 30% when you use single agent DARA. It's really curious how that and why that is. Is it that we have lower tumor burden, et cetera, something just different about the biology? And then if you see CR rates, really high CR rates in the Boston group, 40% with the single agent DARA or DARA with some steroid versus only 15% in the French study. But when you look at the VGPR, 45 and 42 here. And again, the German study was more akin really to the French study. And then, organ response in a goodly number of patients, again, not really long follow-up. But what is, I think, really interesting is that the median PFS in the BU study was 28 months, and they had 24 months of planned daratumumab. In contrast, the French study, where they only had 24 weeks or 6 months of dara, their PFS was also, it was very similar. I mean, it was 25 months, which is just sort of food for thought. And then again, here, if we look at the German study, the PFS was not as good. They were treated for shorter periods, but it was, only 12 and 19 months, but they did have short therapy. So again, it is effective. How long do you use it is anybody's guess. And that's what we know. But I want to talk to you about venetoclax, because this is really an amazing drug in patients with translocation 1114. So this is a collaborative study that was patients were put together from multiple institutions based on their use of compassionate use venetoclax in patients. And there were venetoclax, it might just be alone, it could be with steroids, it could be with another agent. It was kind of a gamish. And it's only 27 patients that had translocation 1114 in this study. And I'm just going to focus on those. And so recall, if you do FISH on patients with amyloid, about 50% will have translocation 1114. That's supposed to make it such that patients with 11-14 do not have as good a response to bortezomib. They seem to, you want to make sure you have some alkylator there for those patients, it appears. But again, 50% of patients will have this translocation. So compare it to myeloma, where it's only about 15% of patients. So looking at these 27 patients, 41% had a CR and another 37% had VGPR for a 78% VGPR CR. This is in relapsed patients or relapsed or refractory patients, which is quite extraordinary. And then I basically made this curve off of their curve to make it, because their curves are really awful looking. But basically, I put overall survival. So of these 27 patients, all of them, it's only 14-month follow-up, but again, their survival, nobody died, except this one at the very beginning. And same thing for progression-free survival. So overall survival at 12 months was 97% and PFS was 90%. Really, really good medication. And this is, I just have to show you this because I think it's so cool. This is one of my patients who was diagnosed with amyloid in 2015, and he had a little bit of heart and kidney and possibly GI. And he was given Cyborg-D and, kind of came down, but not really. So we even tried some Revlimid because his insurance wouldn't pay for POM. So it came down a little, but nowhere where we want it to be. So then we tried even Velcade Revlimid Dex for 3 months, and it came down a little bit more. Then we tried daratumumab Revlimid Dex, and it came down even a little bit more. And then we just did Dara maintenance. But again, his urine protein was sort of holding still high. This is, 2000 milligrams or so. He clinically didn't feel great, but he continued the Dara and he started progressing. So again, this is now 4 years into his diagnosis. He did get, a VGPR, but never a CR. And so we got venetoclax on compassionate use. And we used it for 9 weeks. And he's like, I don't know, I think it's making me sicker, whatever. But we gave it to him. And with the treatment, it went boom, down. His light chains dropped. And he had his last venetoclax in June of 2020. And we kept saying 1 month at a time, 1 month at a time, we'll see. If we start progressing, we're going to go back on it. And again, he decided it really didn't necessarily make him that sick. He was just not feeling well on his own. I just saw him yesterday, and he's in a CR, and his urine protein now is down to 500 milligrams. And so remarkable, 9 weeks of venetoclax, and that's it. CR when he couldn't get it with all these other things, and he's off therapy now. I'm not saying that this is going to work for anybody else in the world, but it's just really kind of a fun case. I'll tell you quickly about the Tourmaline study because it is a randomized trial. 85 relapse refractory patients, 85 and 83 randomized to physician's choice or Ixadex. And, we had Meldex, Cyclodex, Thaldex, Revdex were all the choices, and patients would continue. They were stratified based on risk and prior PI exposure. And the endpoints was hematologic response, 2-year vital organ deterioration or death, and overall in heme survival. And in summary, it was the first phase 3 trial in relapse refractory AL, and it showed some improvements in outcomes. The first of the 2 primary endpoints, the heme overall response, was not met. Ixadex did get a deeper CR rate, 26 versus 18. So things like Meldex and Lendex did better than expected. But they also had a higher vital organ response rate, and Ixadex prolonged time to organ deterioration and death and PFS and time to subsequent therapy. And it was well tolerated. So patients were able to get treatment twice as long as physician's choice. And these are just some of the curves. So here's vital organ PFS, and here is hematologic PFS. Wasn't really significant different, but a trend. And so this is the summary for AL, but we're not done. So don't walk away yet. the AL, I didn't talk about doxycycline tons, but it is reasonable to add for your advanced patients. Just be careful with photosensitivity and GI toxicity. First line is DARA VCD. Alkylator, I alluded to, is important with 1114, but if you're using DARA VCD, you have the Cytoxan. I think the rates of transplant are going to drop. We're striving for VGPR or better. I didn't have time to talk about MRD. You'd want to treat, we don't know exactly when you treat patients with amyloid, but you want to get them when they're having heme progression and not organ progression. New darling for 1114 is venetoclax. There are trials to be coming, and there's a lot of work to be done. But I want to come back to my patient here because during his course, this is the guy I started with, the guy who was smoldering. He had a bone marrow as part of his evaluation. We're trying to figure what to do. And he'd never had mass spec. So we said, we should do mass spec. Well, when we did mass spec, there was both kappa amyloid there, but he also had ATTR, a hereditary form. His heart was fine. We did peripheral blood to confirm the mutation. And we did the original bone marrow from 2006, and it was AL, it was kappa. But the point I want to make is that people can have multiple kinds of amyloid. So not only can they kind of trick you by having a monoclonal protein and have a different kind of amyloid, this guy literally had two different types of amyloid, transthyretin inherited, and also the and AL. And so I've said this over and over. And so I'll say the second point: existence of one type of amyloid does not make one immune to other types of amyloid. And what we are seeing is patients who have AL, they're in hematologic response, they start getting cardiomyopathy, and because they're older and they're getting age-related amyloidosis. And I want to show you this. This is very busy, but this is like 16,000 mass spec of the amyloid tissues done at Mayo. And it's by where the biopsy was done. Amyloid, so of the bone marrow samples, 1,200 bone marrows that they typed in our lab, 80% were AL. But just because the amyloid's in the bone marrow, it could still be ATTR, as was in the case of our patient, and AL and all other kinds of different types. And so just to remind you, there are a lot of other amyloids. And with the last couple of minutes, we talked about this diagnosis, but the other side is if you have a suspicion for amyloid and there's no monoclonal protein, if there's a renal phenotype, you do the FAT. If it's negative, you have to biopsy the affected organ. And it may be a completely different type of amyloid. Now, except for ATTR, there's no therapy, but you want to get the thing right because you don't want to give these other patients the chemotherapy that we would be doing for the ALs. Same thing for liver and nerve. You just want to figure out what it is. Now, nerve can often be ATTR, and I'm going to show you very briefly all the therapies we have there. For cardiac, this is the only instance where we can get away without getting a tissue biopsy. So if you have a cardiac phenotype, no monoclonal protein, normal free light chains. If you do a technetium PYP or DPD, and that's positive, ATTR is very likely. You can sequence it to see whether it's wild type or hereditary. If the PYP DPT is negative, then you can, if you really think it's what it is, you could do a biopsy of any other tissue. If the heart's negative, you're in the clear, but if something's positive, then it's the same algorithm. And this is just an important paper where you can use non-biopsy means of diagnosing transthyretin amyloid. This is a common entity. If you look at autopsy series of people, so this is age-related, used to be senile, called senile. If you look at autopsy series, men or people over 85, a quarter of them will actually have ATTR. If you look at people who are screened with carpal tunnel release and they're a little on the older side, 10% will have any type of will have amyloid. HFpEF patients, heart failure preserved EF, 13% will have amyloid. And so we're learning spinal stenosis. If you look at the ligaments, a lot of these are actually amyloid. So, but it's TTR, or half of them are TTR. So we need to know about this so we get our diagnosis right. And just to tell you that, transthyretin is made in the liver. It could be wild type, it could be mutant. And what happens is you make messenger RNA so you can translate it to the protein. There are two drugs, inotersen and patisiran, which basically are silencers. They knock down, they make it so you don't make protein that at an RNA level. They do RNA to protein level. And so they are sort of doing what we do with our chemotherapy for plasma cells, but here they're just inserting or affecting the ability for a messenger RNA to transcribe into protein. And then there's also stabilizers like diflunisal and tafamidis, which again, transthyretin hangs out in as tetramers for monomers together. If they fall apart, then they can form amyloid fibrils. If they're not in that stable tetramer configuration, then they can make oligomers and fibrils. So these drugs, tafamidis and diflunisal, will keep them stabilized so that you don't go down this path. So these are different mechanisms, and basically showing you that tafamidis in cardiac amyloid, 30% reduction in risk of death. So there are medications to treat ATTR amyloid involving the heart. And then also for nerve ATTR amyloid, so the ones who have neuropathy, at least in the US, these drugs have been approved, inotersen and patisiran. And what we're showing you here is their nerve score, this is from baseline to, a little after a year of being on therapy, whether they get placebo, their score gets higher or worse. On inotersen, it gets less worse. For patisiran, it gets worse if you're placebo, but if you're on patisiran, there's even a trend that it might be getting better. And again, symptom scores improve. And so these are really important drugs. They're in trial for heart now, and there's some different versions of them, so they're more convenient and so forth to administer. And then just the last thing is CRISPR. This was in New England Journal just this past week, where literally they're using CRISPR in people, 6 patients, gene editing to cut out transthyretin so that you can't make transthyretin. So a little scary because this is a little bit of a permanent thing, but proof of principle. This is 3 patients that got 0.1 mg per kg. Here's 3 patients who got a higher dose, and you see that the change in their serum transthyretin levels drop significantly by day 28 in the low dose, and even more significantly in the higher dose. And so this is sort of permanently doing what those silencers are doing, that you have to keep administering the drug. And with that, I thank you for your time, and happy to answer whatever questions you might have. Thank you.
Thank you so much, Dr. Angela. That was wonderful. You covered almost everything, and there was so much new information. I'm sure everybody has benefited, whoever has logged in and whoever is here. So we have some Indian faculty here. They would like to ask their difficulties to you, starting with Dr. Sharad Damodar.
Thank you, Dr. Angela, for an absolutely brilliant talk. I have one question to just start off in 2 parts. The first one is, in our country where, due to economic reasons, we may not be doing DARA cyborg decks, where we tend to do cyborg decks, kind of get VGPR and take them for a transplant. Is there a role to keep some kind of maintenance medication on, like the myeloma setting? And the second part is, have you had issues when you're collecting stem cells in patients with cardiac amyloid during the pheresis?
Okay, so maintenance in general, no. If they get post-transplant in general, unless like they really are, it's rare to have like a deletion 17p or translocation, 414. I mean, it happens occasionally, but it's really small numbers. So in those patients, they make me a little uneasy. And so I would sort of think of them a little bit more like a myeloma patient and think of some kind of maintenance. That too, patients with the higher plasma cell burden, I would also consider those patients for a maintenance. So if they have 30%, 40% plasma cells as part of their presentation, and I might in that instance do it. What maintenance would I use? So I'm not a big fan of IMiDs in amyloid, Revlimid and, thalidomide. I think they can be pretty toxic, especially in the newly diagnosed population, because those patients can be so sick. But if somebody's already survived transplant, you've already selected. And so, you can use Revlimid in those patients, though you do want to be cautious about the dose that you choose, because like I said, even in newly diagnosed, they really get some cardiac toxicity. And so if I use Revlimid in those patients that kind of I really feel anxious about, and I want to do some type of maintenance, I will watch the cardiac biomarkers, and I let them go up some, but if they're going up, or the patient's telling me they feel miserable, or their blood pressure is really low and they're orthostatic, then I either drop the dose or discontinue, or it's always a calculation. So that was your first question. And then your second one, I talked so much I forgot.
The pheresis complications in the cardiac amyloid patients.
Yeah, leukapheresis. So we used to have a lot more difficulty with it, but because before we were as selective as we are, so in terms of, we don't take very sick patients through transplant anymore, because honestly, the results for the BMDEX trial, or even retrospective data from CyBOR-D, patients really can do quite well just with that. And even like 4 to 6 cycles worth, and, call it, they really can do well. And so, if they have higher troponins or higher NT-proBNPs, or their renal function is on the cusp, I'm ambivalent about taking those patients to transplant. So when it comes to the leukapheresis, some of the sickest patients, we're not leukapheresing them. And so leukapheresis, by definition, is going to be easier in that kind of a patient. When we used to take sicker patients through, we had a lot of trouble with the leukapheresis, both blood pressure, fluid retention. Now, that said, you have nephrotics where you might also, have their hearts are good, but their albumins are, like 1.6. So, they third space like crazy. And in those patients, yes, sometimes you do have issues with, the leukapheresis, so because the growth factor can cause, fluid retention, and just being on the machine, the fluid retention. We tend to use split dose. We give BID GCSF. There was, I can't remember the reference anymore, but, 15 years ago or 10 years ago, probably 15, there was this paper in just myeloma about, less fluid retention and side effects with split dose, GCSF. So we do that, number one. Number two, if we do have issues with fluid retention, then we'll, if it's really significant, like 5 kilos, we'll delay a little bit on the transplant, try to diurese them down, even albumin diuresis, if need be, just to, because if their serum albumins are so low. So that would be the bigger, kind of the biggest thing. Where patients sometimes, I've seen 1 or 2 splenic ruptures, with leukapheresis, but really rare kind of event. But yeah, since we pick less sick patients, we have less leukapheresis issues than we had previously.
Right. Thank you so much.
Thank you, Sharat. We'll take one question from the audience. Dr. Kalantri wants to know, how common is isolated liver amyloidosis? And do you do anything different for them?
How common is isolated
Liver. Right.
So I presume you mean AL, amyloid. And so if you look at all patients, it's only about 15% have liver involvement. And of those, what percentage have only liver, don't have heart, don't also have kidney? it's going to be a small fraction of that. I don't have a precise statistic, so I would say, isolated is probably going to be 5% of, of the livers, and you only have 15% that have liver. Isolated is a funny word because it isn't. It is potentially isolated, but it's not localized, right? Because it's systemic amyloidosis. So the bone marrow is driving it, and it is a disease that would require systemic therapy to kill plasma cells to then, improve the liver. But it is a pretty unusual manifestation to be purely isolated. The vast majority will either have heart or kidney with it.
Thank you. Dr. Dipanjan.
Thanks for the amazing talk, madam. My question is regarding cardiac amyloidosis patients. So when these patients have got extensive cardiac involvement and you're starting them on chemotherapy, be it Cyborg-D or Dara-Cyborg-D, practically, what is the incidence of cardiac arrhythmias or sudden cardiac death that you see in these patients, and how do you counsel this patient?
Yeah. So that is getting back to the cardiac biomarkers, because, we know, and I could even sort of show, the slide again, just to sort of make the point. But, if a patient has an NT-proBNP greater than 8,500, depending on what the rest of their biomarkers are, it's like a 60 to 80% chance they're going to die within the first year. And most of those deaths are happening in the first 3 to 6 months. And so, these are patients with a true unmet need. And, we've been talking in our group, is there something we could or should be doing? I'm going to just share this just briefly here, because I think it's of interest. So this is just looking at the, the 2012 stage. But here, if you look at patients who have an NT-proBNP greater than 8,500, who are also considered to be stage 4, so they have a free light chain that's the DFLC is greater than, it should be per deciliter there. But anyway, you see that 45% of them are dead in 3 months. And if they're stage 3 patients, so that, they have only 2 of the things that are abnormal or extra high, it's better for these patients. They're not as many are dead early on, but a year, 60% are dead. And so with that in mind, we've been talking, should we be doing, what can we do differently, right? In terms of, do you put these patients in the hospital? ICDs, there's not really prospective data on that to say, a lot of times the ICD doesn't work. We've had, we have many patients who are coded in the hospital, with a full team there, and they still die because their heart is that bad. Do you think of doing heart transplant in these patients? Again, a lot of resources. If you really are identifying these high rate of death patients. There was a study out of the National Amyloid Center where they had devices in patients, and they saw that a lot of patients were dying, or not a lot, but a proportion were dying of bradycardias, bradyarrhythmias. They would just get like heart block and die, as opposed to, people always were thinking, VFib. There's a lot of pulseless electrical activity, that happens in these patients. So what do we do with them? I personally, we try to watch them carefully. We don't really hospitalize them because we don't have the resource necessarily to do that. I do caution them that there is a risk for sudden death, but, we're giving them the very best therapy possible. And we're hopeful, because it's not that everybody dies, and we're hopeful with these really good therapies that we will turn things around. We are meticulous about following electrolytes. So, potassium and magnesium, calcium, sort of just kind of keeping track of those kinds of things, watching the NT-proBNP cycle by cycle. But, the sudden death is a real thing, and it's just heartbreaking. But in my dream, it'd be like, could we just put these patients in the hospital and, put them on a heart transplant list and, see what happens and give them chemotherapy in the hospital and just keep your fingers crossed. I mean, it's not something we're currently doing, but that would be my choice if I were in charge of health insurance and all the resources and so forth.
Thank you, Deepanji. I'll take one more question from the audience. Short of DARA, what will be your next best regimen? Will it be, no, he hasn't mentioned anything. Whichever will be the best next?
Yeah, I think that the combination of an alkylator, whether it's cyclophosphamide or melphalan, along with bortezomib, with dexamethasone and the dex, you kind of do the 20 if they have advanced heart, and 40 once a week, with the less advanced heart. And we use weekly bortezomib and weekly Cytoxan, or the melphalan is the 4 days. So that, I think, is a really good option if the patient is a sick patient. And again, the rule is you check them after 2 cycles. And if they're not in a VGPR, if you have the resource available, trying, something else. Now, what would that other thing be? Would it be an IMiD if their heart isn't too bad, and just really careful watching? I think that's something you could try. If they were 11-14 and you had venetoclax, that one is a major winner. So that would be if there's the sicker patient. If they're a healthier patient and I didn't have DARA, I would do the Cyborg-D and I would transplant them still. And because I think that you get really, good long-term outcomes, and it is among the highest response rates. Though that said, the Europeans are not big fans of doing transplant. There was the IFM study from many years ago that was, a negative study in terms of transplant providing benefit, but they had such a high treatment-related mortality, and it was a small study. Now, one of the couple of supports for using transplant many years ago, a couple of decades ago, I did like a case match and, showed that it appeared that transplant was providing benefit. The UK group did just recently published a paper comparing transplant to, like VCD, and they propensity matched them. And they found that survival was relatively similar. Progression-free survival was better with transplant. CR rate seemed to be a little bit better. And the other thing you have to take in mind with that particular study is when you look at the populations that they were looking at, the transplant patients were patients from longer ago, and the VCD were the more modern patients. So if you're looking at overall survival, if you're in a more modern time frame, you likely have more drugs available when they relapse. And so, that alone is going to give them a better survival as compared to when you look at a older a population from a longer time ago when there weren't drugs, other things like all it was alkylator and steroid. So you have to be careful when you're looking at populations from different time periods. But again, so that they were trying to make the point that transplant isn't necessarily better because you can salvage people with other things. And I do believe that on some level, and that's where I feel very comfortable not transplanting the sicker patients, because I think they have really good options, and that, if the risk of transplant related mortality is going to be high, I don't feel like I'm cheating them of anything. I think I'm giving them really, really good therapy, even with BMD or VCD. I think I'm giving them excellent therapy. But for the healthier patient, it's the transplant, it's done. And, we have such good results for long-term. So that's where I tend to go there. I hope that answers it.
Yeah. Dr. Afaq Ahmed.
Thank you, sir. Thank you, ma'am, for a wonderful presentation. My question is, what are the exact cutoff levels for monoclonal immunoglobulins and organ dysfunction to call it a relapse so as to start the treatment?
Oh, you ask a hard question. That's like the hardest question so far. So we didn't have time to go into this whole thing about progression and relapse, because this is the biggest weakness in the whole amyloid field. And it actually troubles our clinical trials a lot, because the current definition for relapse, according to ISA criteria, is that you need to have a DFL, the DFLC has to go up by 50%, but which also has to be at least 10 milligrams per deciliter or 100 milligrams per liter, which these days with such effective therapies, when it was written in 2005, we were happy to get a partial response, and a VGPR it didn't exist as even a term, so a DFLC of 10 or 100, that sounded reasonable. Nowadays, people will bail on a therapy way before they get to the definition of progression. And so that stymies our trials. In real world, the parameters and the markers that I use are several. One is, how high was their light chain when they were first diagnosed? If they were a person with a really high light chain at the beginning, you figure it took them a while to get symptoms and their light chain was not, that toxic. I mean, it had to get to just such a high level in order for it to cause difficulty. And so that will color my thinking a little bit. If they had a really low light chain, let's say they presented with fulminant horrible amyloid with a DFLC of, or a free light chain, involved free light chain of, 7 milligrams per deciliter, I'm going to really they're falling out of CR and, they're just sort of creeping up even before close to 5. I'm seriously talking about, should we try something? In contrast, if it's somebody who, had a free light chain of, I don't know if you guys do it in mgs per liter or mgs per deciliter. So how do you report your free light chains?
We do liter.
Per liter? Okay, so I'll do talk in mgs per liter because I don't know which way to go, and that's more confusing when I go back and forth. If they have, so if they had, a free light chain of 70 at diagnosis, then that's pretty low, and that would be, somebody I would want to get on sooner. But if they had a free light chain of, oh gosh, like 1,000 or something, I would have a little more tolerance. Also, if they're a renal only patient, like they had only nephrotic syndrome and, they weren't that sick and it was like incidental finding, I might have a little more liberty to, do it in terms, but a lot of folks are really starting with a DFLC of, around 40 or 50. And that's the way the trials are being written to, start there, because people are expecting to have patients in VGPR. If you're not in a VGPR and you're not meeting definition for VGPR or CR, you've essentially failed, is kind of the thinking. And so that's where the level is somewhere around a DFLC of around 40 or 50 is a reasonable place, but there's a lot of qualifiers there. A long answer for what you thought was probably a simple question, but it's actually a really hard question.
Thank you.
Thank you, Dr. Afaq. Another question from the audience is, can amyloid P component be used as a pan-amyloid marker?
As a marker? Well, it's used as a marker by mass spec. So SAP is one of the peptides we see when we do mass spectrometry of the amyloid, and it lets us, like something like what light chain deposition disease doesn't have SAP typically traveling with it. So it is a marker when you're doing mass spec, that and ApoE and ApoA4. but in terms of SAP, if you're doing immunohistochemistry, you can see that there as well. It's not really used much as an immunohistochemistry thing. And then, as I mentioned, it was used at one point. There were thinking that would be SAP depletion would be a therapy for amyloid. And that program shut down when they had the combination of the CPHPC, which was something that lowers blood SAP levels, and also an antibody to SAP. They had toxicity. They had like sort of vasculitis in the heart. And so they shut the program down as a therapeutic strategy.
Thank you. Dr. Lingaraj.
Thank you, sir, for the opportunity, and thank you, Dr. Angela, for this excellent talk. So I have got two questions. One is related to translocation 1114. So as you have seen that the CyBO-D is an inferior regimen if it is 1114, and that is found in almost 50% patients. And your group has in a couple of years have shown that melphalan is a good option if it is 1114. It aggravates the poor prognosis of 1114. And the recent data of bortezomib mel-dex, do you think in 1114 we should shift to boti melphalan dexa as opposed to CyBO-D if you are not using DARA? And that second question is related to MRD. Now the data of MRD is little emerging in amyloid, and if you are not using DARA, CyBO-D and CyBO-D based regimen where patients have achieved hematological CR, do you think an MRD positive patient we should continue treatment because the depth of remission matters in amyloid?
Yep. So 1114, so I would say that 1114 patients don't respond as well with Velcade, but they respond with alkylator. And I would say whether it's Cytoxan or cyclophosphamide or melphalan. So as long as you're, so there's this controversy, do patients need to even have alkylator? Could they just go with Velcade and Dex? And I would say, if it's a non-1114 patient, I don't have an issue with that. But if it is an 1114 patient, I would want to put either cyclophosphamide in or melphalan as part of the program. I wouldn't exclude the bortezomib. I would use it as part of the program, but I would for sure want the alkylator or as part of it. And transplant alkylator also is a good option there. So I don't. If you were to ask Dr. Merlini, Professor Merlini, I think he likes melphalan better than cyclophosphamide, but I don't think it's so much different. In terms of the MRD question, so again, there's emerging data on MRD and different levels, right, of MRD. So the current definition, at least in the Palladini paper and was that you don't even have to do a bone marrow. Some of the and so CR, as long as you're fixed negative in the serum and the urine and you have a normal free light chain, then you're a CR. And you don't have to have the bone marrow. And so people have gone and done gradations of that thought experiment. So what if you have a negative in that circumstance? So the blood and the urine is as such. But if you look at the bone marrow among those people that just by morphologic immunohistochemistry, positive, negative, or if you look at flow cytometry, low resolution flow versus, next gen flow versus, next gen sequencing, a kind of, because it's all a spectrum, right? And more or less what you see with each of those, the deeper you go, yes, there is a difference. You're probably more likely to have an organ response and a better progression-free survival the deeper you go. Overall survival, I haven't seen any signal yet with those things. Now, maybe some of that is that the studies aren't old enough because MRD hasn't been happening that long. So you can't follow, you don't have like 10-year follow-up to see separation of a curve. I don't know the answer to that, but everything so far is the most telling thing with the MRD is better PFS and higher organ response. Now, would you continue treating somebody just because they're MRD positive and or would you change therapies to drive them into MRD positivity? At this point, no, I really wouldn't. Now, you're always looking at the same time at organ response, right? So if a patient is, a renal who's not that symptomatic, but they have proteinuria or whatever. And, so it's going to take time for response. I showed you those curves. I mean, to get a 50% reduction in urine protein is like that median time is over a year. I mean, it takes a long time. But, I can wait it out, and I'm not going to necessarily change therapy right now for that. Now, if a person has significant cardiac involvement and, they're functionally really not good, and, we're looking at them and, there really is not a lot of movement in terms of their overall improvement in functional status, or their cardiac biomarkers, the NT-proBNP is not improving. And and we're at 6 months and or more, it really like no difference. And now, first thing I'd ask is, is the drug causing some of the rise in the biomarkers? So, I might say, okay, I'm going to, they're in a CR. But, I am giving them steroids as part of their thing, so let's just give them a month or two, see what happens, and then you watch them and they're still symptomatic. And, you say, well, they're still kind of miserable. I don't see, any hint of organ response, or very little organ response. And we're 9 months in here, and, I'm not giving anything to make them sick. I'm not giving them beta blockers, which can also make their hearts worse. I'm not giving, something that's, afterload reduction and making them so they're fainting every 5 seconds, because I don't need to afterload somebody with diastolic dysfunction, so all those boxes are checked. And, I'm kind of like, maybe we should try something, maybe their light chain is so toxic and it's, I don't see it in the bloodstream. It's like, jumping into the tissues before, I can even measure it in the bloodstream. Let's try carefully to try something else to drive them down. But, I wouldn't necessarily do that, for a while. I mean, that's like a year in, 9 months at the soonest for sure. But I wait a while personally to do that.
Thank you. We take one more question from the audience. Do you have patient of AL amyloidosis where the protein profile is entirely normal? No M band in the serum, urine, and free light chain assay is normal? Yeah.
So it's like maybe 1% of patients. Before we did mass spectrometry, before we actually typed the amyloid, we had a much higher percentage of patients who didn't have a monoclonal protein. We were saying they had AL, but they actually didn't. They had amyloid, and we didn't know better, that there were other amyloids back in the day, and we weren't thinking, and so it's like they have a biopsy, it's amyloid. Well, what else is it going to be? It's going to be AL. So if you have the diagnosis right, where really it's like 1 or 2%, it's very unusual.
Thank you. Dr. Sharad?
Yeah, one last question. So, Dr. Angela, how important is it to get mass spec done? Because that access is clearly difficult for us. So, how important is it to try and push for that?
I when I first came into this business, I was really surprised that we would, the recipe was a monoclonal protein and amyloid was AL. It just didn't make sense to me. And sure enough, we were able to do immunohistochemistry, and it's okay. Again, if you have somebody who you really want somebody who does it all the time. I mean, there in Germany, there are pathologists that, yes, I would trust it in their hands, because I mean, they've lived their lives doing this. They have amazing antibodies, but a run-of-the-mill pathologist who doesn't do it very often, it's a mess, and you might as well almost not even do it, in truth. So then the question is mass spec. So I find it really important. Now, that said, if you have somebody, with really high light chains and, really, a good plasma cell burden, and they have, like periorbital purpura, because that you don't really see so much in ATTR, and jaw claudication is not so common in the other amyloids either. So there's some of these other weirdo things. And if they also have like heart and kidney, and the monoclonal protein, like all of these things are like pushing me closer and further to AL. So, and the other thing, like if they're seemingly a cardiac only, so a really important pearl is if their echo looks sicker than the patient, like it's a really ugly echo and the patient's not that symptomatic, it's not AL. It's ATTR more than likely. It's amazing. These patients can have these thick septums. I mean, they're like, 20 millimeters, normal's like 11, right? 20, and the patient's like, yeah, when if I walk up hills really fast, I'm short of breath. That's not AL. That I would, give you my house if that was AL, with that echo and that symptom status. That's going to be a different kind of amyloid, more likely ATTR. If they're really sick and their heart is stiff, but it's not huge, that leans a little bit more towards AL. So there's some things that, sort of this kind of your pre-test probability that is going to get you there. The heart alone patients are tricky. I don't know if you have like PYP, the technetium scans, the old MI scans. Those are kind of, I guess like if you have a monoclonal protein and if it's whoppingly positive, I would think really strongly is this TTR. And maybe it's hard. I'm so spoiled that it's a little harder to think out the box. There are instances where you do, just based on experience, you feel pretty good about it, and you'll start them on treatment even before the mass spec is back, with the knowledge that you can stop if it's otherwise. So, but again, the biggest competitor truly is the TTR and the age-related TTR in the elderly. And so if it's cardiac and then they also have, nephrotic syndrome, it's more than likely not going to be TTR. A rise in alk phos, you can get congestive hepatopathy if they have bad heart failure, but usually their hearts are a little on the bigger side. So that's something. And the nerve, if they have nerve involvement, that could be TTR, the hereditary form. So that gets tricky, and heart and nerve, that could be hereditary TTR. So that gets tricky. And then there are all these other weirdo ones, like, the ApoA1s and the ApoA2s and the lysozymes, but they are pretty rare. So, I know I've treated people with hereditary amyloid with melphalan and prednisone. When I first start, nowadays we know the difference, but Bob Kyle has done it, Maury Gertz has done it, we've all done it, and you just have to go with what you have. And so you just have to make the most sense of it you can. But I think the higher the free light chains, I think you should be very suspicious if you don't have elevated free light chains. I would be, just a monoclonal immunofix positive without light chains. That heightens your suspicion that it may not be AL. It still can be, but I think it really, you just want to think. And so I would maybe reflex that one to some kind of typing more so. And then again, it's just really the overall phenotype. But if they have some of those, periorbital purpura, that gets you a little closer to AL, and the jaw claudication. So yeah, it's hard, and I'm spoiled.
Right. Thanks.
Thank you. There are questions related to 1114, and I'll just put all of them together. What is the best tissue to diagnose that there is 1114?
Translocation 1114 is on the plasma cells, right? So it's just your bone marrow biopsy, just like a myeloma patient. We do FISH and you see the translocation 1114.
The other question is, if it is positive, why not to use venetoclax upfront for all these patients?
I would love to do that, but it's not available. I think it's going to be really, it's going to give daratumumab a run for its money, in that population. I've treated a handful or so of patients, and I've been in the amyloid space, and been really impressed. And this one like anecdote that I gave you, which is totally an anecdote. I mean, but it's like I just saw him yesterday, and I'm just like, I cannot believe we gave you 9 weeks of therapy and it's a year and you're in CR. I mean, it's like, it just makes me smile. It's just one of those like happy things. And I'm incredulous. So I think down the road, it may well be the right therapy, but there are going to be clinical trials starting to use venetoclax in these patients. And, we know in the myeloma space, for example, from the Bellini trial, how, there was a higher death, you had CRs and things in the 11-14s and the population at large too, with bortezomib and venetoclax. But you had even though you had higher response rates, you had a higher death rate due to infection and other kinds of things. But when you looked at the subgroup of the 11-14s, there was a benefit. And so, we don't know. There may be some undue toxicity that I don't know about in AL patients because I don't have enough experience. So I think we need to study it. But I think your prediction is a good one, that perhaps someday that will be the first line therapy for patients with translocation 11-14.
Thank you. Another question is the TROP-T and anti-pro-BNP, if they're elevated, do they always mean cardiac amyloidosis?
So the troponin T and the anti-pro-BNP, does that always mean? No, they're not specific. There was an interesting paper out of the National Amyloid Center where they were looking at, they did a cutoff of 152 instead of like the 332. And they showed that having a slightly higher NT-proBNP or an elevated NT-proBNP, but not even as high as 332, was a significant prognostic marker in these patients. And then they also showed that, MRI was a really good way of diagnosing early cardiac involvement. Now, NT-proBNP is a crazy test. You have salty food, one night of a salty meal, and it's going to change. And so, and all kinds of things that cause cardiac stretch will cause that. So, people can have other things wrong with them. Certainly, if you have renal failure, that's going to drive it up both of those markers a little bit, because they are catabolized or excreted through the kidneys. So that's an important piece. So they're not that specific. If you ask my cardiology colleagues that do consult service on the hospital, that one of the banes of their existence is, the consult, unknown reason for elevated troponin. Please help us, and it's like, is what their feeling is. Now, some of them could be amyloid, but, there are things that are going to cause ischemia. So they're not specific, but I think that they are, in the right clinical context, important. And that said, when we did these staging systems, we didn't prove, go and biopsy everybody's heart to know. But the reality is, if these numbers are elevated, whatever the reason, something's not right, and that's not good, so if it's another cause or whatever, you're having myocardial ischemia because you have really bad coronary artery disease and you're getting troponin leak, that's bad too. So you have to put it in context and make sure you're not missing other things that are treatable, but it's still going to be prognostic, but it's not diagnostic necessarily.
There's a question related to MRI of the heart. Is it the usual MRI, or you require a special software?
Yeah, so there are certain routines that you do. I mean, the gadolinium enhancement is, again, I'm not a radiologist, so I don't know, all the variations on what softwares are, come part of the package. But the GAD enhancement is it seems to be a pretty routine kind of algorithm, but I can't answer that. Certainly the looking for extra volume, extracellular volume, that is a specific routine, a very different routine. So one is just making the diagnosis and seeing delayed gadolinium enhancement. And we see that coming from like all kinds of institutions. So, and they're not amyloid institutions. So I think it's a common routine or software package. The extracellular volume question, which is something that's prognostic, and you're just kind of, they're looking to see, is there more literally like, edema in the heart, so to speak. That is a different kind of a software, but that's more of a, yes, it can be used for diagnosis, but it's really like a prognostic thing. And again, this would be the National Amyloid Center. They would say in the UK that, it's something you might even be able to follow, for improvements and things like that. But that, yeah.
Thank you. Dr. Deepanjan, you have a question? Unmute.
Sorry, I've got a basic question actually. So in your diagnostic algorithm, the chart which you showed, you had mentioned both about the serum as well as urine immunofixation and free light chain ratios. So my question is, like, in patients with symptomatic organ involvement, in what proportion of patients do you actually get the serum is negative but the urine is positive?
The serum is negative, but the urine's positive. Is that what you said? I didn't hear the last part. What percentage would?
So in what percentage of patients you would get monoclonal protein negative in the serum, but positive in the urine, those patients with symptomatic organ involvement?
And are you calling out, when you say serum, do you mean just fix, or do you mean fix and free light chain of the serum?
Both serum immunofixation as well as free light chain.
Yeah, so you only capture a couple of percent. It's not a very high number. It is not. So there's a paper that Jerry Katzman and I did, I don't know, maybe 15 years ago, that really goes through the combinations, like what you buy per disease, per diagnosis, by, omitting something like, so for myeloma, you could really screen for myeloma and get like 99% with just an SPEP and a free light chain. And, you don't even have to do the urine and an immunofix as a screen. Truly, you're capturing like all but a couple of percent. It's really good. When you get to amyloid, you definitely need the immunofixation of the serum and the free light chain. But the urine really adds like 1 or 2%. It's not a lot.
Thank you.
Thank you. Do you use doxycycline in your practice?
I do for the advanced hearts. I try it. And, if they have issues with GI toxicity, and you tell them, wear a lot of, sunscreen if it's summer and they're going to be outside kind of thing because of the photosensitivity bit. And so you figure, what do you have? If they can tolerate it, it's not a terribly expensive medicine. And if it does something, great, but I'm not going to, beat the patient to smithereens to make sure they take it. And I even tell them, doxycycline is supposed to take it on an empty stomach. And I know personally, I can't take it on an empty stomach. It really upsets my stomach. So I say, even if you can't, if it makes your stomach upset, take it, with even little food, maybe it'll do something. I know I'm interfering with the absorption, but.
The other part of the question is, how long do you continue and what dose do you do?
Yeah, so 100 once a day to 100 twice a day. It could be either. 100 once a day is a lot easier to do, and then 100 milligrams. And as far as how long, the other part is having a little gram-positive coverage is not a bad thing as you're giving them chemotherapy, right? So you're getting that added bonus. I tend not to use Levaquin in patients, amyloid patients. I do it in the myelomas, but I don't as much in the amyloids as, a prophylaxis. I do use acyclovir when they're getting the Velcade. But the doxycycline, you're helping protect them against overwhelming gram-positive sepsis, maybe. And usually it's kind of, if they're tolerating it well, I'll use it for, the year, or just 6 months or something like that. And, it depends too, because if they're getting better and then let's say they go to transplant, again, this is, pre-Dara Andromeda. But if they, let's say, were significant cardiac cardiac and they then get good enough that we can consider transplant. So then we take them now to transplant. We give them, an antibiotic for gram-positive coverage, and we tend to use doxycycline in our amyloid patients. Just again, why not? As long as they can tolerate it, because our first line is penicillin, right? We use penicillin 500 BID as our gram-positive coverage as part of our transplant program. So we use the doxycycline there.
Thank you. There's a question related to DARA. You prefer to use it upfront or keep it for the relapse?
I think upfront is going to be really the way to go. I really do, because in amyloid, it really is a race. It's a race between the organs, failing you and the person dying because of that, and you getting a hematologic response and salvaging those organs. And so, it's just from that standpoint alone, I think giving the very best that you have as soon as possible and dropping those light chains as soon as possible is really the first choice, that more so than in myeloma. And, like, for example, in the Cassiopeia Part 2 trial with the VTD DARA versus just VTD with transplant and all the rest, you could argue in the myeloma setting. Now, I don't know if you can extrapolate that if you're using BRD or whatever, but for that very specific trial, it didn't matter when you got the DARA as long as you got some. And so, that even though maybe that could be a truth in myeloma, I still, in the amyloid, I prefer to give it up front just to get those responses.
Thank you. Dr. Afar, you have a question?
Yeah, this question is regarding maintenance. If you are using Cybod-D in a case of non-transplant eligible patient, when will you start maintenance? With what agent do you start maintenance? And how long do you continue the maintenance?
Yeah. So the majority, I don't do maintenance because, again, they really have to be patients that frighten me in terms of, like a huge tumor burden, a huge plasma cell burden, or really scary cytogenetics. And the vast majority aren't that. And so, if they get into a CR, the majority, I will just do, 6 months of therapy and then just watch. But if they are somebody that concerns me, then if it's a patient with a translocation 414, I would use a Velcade maintenance or Ixazomib maintenance, because the proteasome inhibitor, at least in myeloma, the 414s, that really does seem to be an important piece. And you could, if they were well enough, you could do lenalidomide if they were, another type of, they just had like 50% bone marrow plasma cells or something, and, they didn't have high risk cytogenetics. If they were well enough, I could try using a little bit of Revlimid instead of, keeping them on the PI, which is less convenient because, it's easier to take a pill, but sometimes giving a shot is easier for patients because it's cheaper, because pills cost more money for them than, at least in the way our health insurance goes, the pills are more expensive. But a lot of them I wouldn't give the Revlimid because I'm afraid of the toxicity in them. And so then you could either do Ixazomib or Bortezomib, twice a month kind of schedule as a maintenance.
Thank you.
Thank you. Dr. Lingaraj.
Thank you, sir. So in the Andromeda paper, so they have used maintenance DARA. So if you are a patient who is transplant eligible and you are using DARA Cybod-D, what is the added benefit of giving that 2-year maintenance?
Don't know. We were just talking about that with our myeloma amyloid group yesterday, and people were the same question, we're just sort of like, some of us saying, well, I bet you don't really need that 2 years, and it's like, well, you can bet as much as you want, but we don't know. I mean, you're probably right. You probably don't, and so that's where I showed you the 2 relapse trials, very small, the BU trial and the French trial, the IFM trial, where they, one of them, the BU trial, they gave 2 years of DARA as a treatment, DARA and dexamethasone or steroid. And in the French trial, they gave only 6 months of daratumumab. And the PFS rates were actually, again, they're tiny numbers, so confidence intervals are going to be huge, right? But their PFSs were actually pretty similar in the relapse setting. So, is 2 years overkill? Probably. But can I tell you that I know that? Absolutely not, because I can't tell you because I don't know.
One question from the audience is, do you find it difficult to differentiate myeloma with secondary amyloidosis versus primary AL amyloidosis?
So we don't use the term secondary anymore. It's a confusing term, right? Because in truth, when most hematologists say secondary amyloid, they mean amyloids, I think, amyloid due to myeloma, like using that word secondary in that way. But in the amyloid world, secondary is very specific. It's AA amyloid, which is an inflammatory form of amyloid that has nothing to do with a plasma cell dyscrasia. And so I just hate that word because of the confusion of the language. And so if they mean really AA amyloid, how do you tell the difference? I tell it by mass spec. But if they mean it in the sense, is it myeloma with amyloid due to myeloma? Yes. In my mind, they're the same. For most patients, the amyloid trumps the myeloma in terms of prognosis, at least in the short term. Up front, what you die of is organ. You don't die of uncontrollable plasma cell disorder, just shutting you down, this proliferative thing. That's not what people die of. They die because their heart is bad because of the amyloid in their heart, or they have renal failure or something like that, or they have liver failure or, whatever. So, can you have incidental amyloid? You just see it in the bone marrow, but all the organs look perfect. You do an echo, you do cardiac biomarkers, you do the urine protein, you ask the patient all their questions about whether they have jaw claudication, purpura, do they have lightheadedness, dizziness, change in their bowel habit, painful neuropathy, etc. You ask all those questions and they say no, 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 no. But the pathologist somehow found amyloid on the bone marrow for you, and that it is AL type, then then you say, yeah, it's myeloma with incidental amyloid, though I must admit, I have I can think of one patient, and I know I have more than one, where eventually she turned into a bona fide amyloid, like her myeloma was under control. And the next thing we knew it, she had pulmonary hypertension and cardiac and biopsy proven AL. And so, it really is, the amyloid will, in the early parts of the diagnosis, trump the myeloma diagnosis in the sense that the amyloid organ dysfunction is what could kill them. When then you get out after a year or 2 or 3, then it is about the clone usually, in terms of, can you control it? And if you can't control it well, then you're going to get further organ deterioration, and that's going to get your patient.
Thank you. Another question is, if you have a patient of AL amyloidosis presenting with severe peripheral neuropathy, what is your approach?
Yeah. So the Velcade all of a sudden is not so appealing in those patients. And so, Meldex is definitely an option. There's report of using carfilzomib in those patients if they don't have cardiac, and that being okay and tolerable. So you could potentially get the proteasome inhibition into those patients in that regard. Or, if you have DARA, I definitely used daratumumab up front in those patients with severe peripheral neuropathy. I don't really, again, as first line, I tend not to go with the IMiDs as my very first choice. I feel like I do better just with like melphalan and dexamethasone than even a CRD, cyclophosphamide, lenalidomide dex or something, or a CTD. So I just go with a Meldex if it's just peripheral neuropathy. But I certainly, if they only have nerve and it is AL and not another type of amyloid, then carfilzomib and alkylator, carfilzomib cyclodex could be used, or a daratumumab based therapy. And sometimes you get stuck. So, it's not your first choice to use Velcade, but even if they have bad neuropathy and you're running out of things and, what you have available, you just go tread very gently and you quiz the patient, because it's not a guarantee it's going to get worse, but it does make you uneasy.
Right. Another question is your experience about gastrointestinal amyloidosis with cardiac involvement in AL amyloidosis.
I don't know exactly what they're getting at. I mean, certainly they're patients. So first of all, when it comes to gastrointestinal amyloid, a majority of patients, if you biopsy their guts, will have amyloid in it. Because it's just a vessel, you're getting you'll see it, but most of them don't have symptoms. So that's number one, is the majority of patients who have biopsy proven GI amyloid don't even have symptoms, because it's really, you got a vessel and it was in that vessel and that's it. In terms of patients who have true gastrointestinal. And so the gastrointestinal comes in many flavors. One can be severe malabsorption in terms of, there's so much amyloid that nothing is absorbed. It's like they have pipes for guts and nothing is going to get absorbed. And that's a challenge in terms of, patients have diarrhea and this, that, and the other. And then, you want to have fluids, but they have cardiac disease. And so you can't give them, IV fluids is easier because you're going to put them into failure. And so, that management, and the same thing with autonomic and cardiac, that can really be very challenging. If it's just GI in terms of, they have a little nausea or something, that's kind of trivial. Or if they have bleeding, again, bleeding is usually not too much of a problem, except, if you get them thrombocytopenic, but it's pretty rare for somebody to die of, bleeding in regular from GI amyloid. But the malabsorption really can be troublesome when they have cardiac, because you're limited. You can't help bolus them with fluids to sustain them and such. And so, looking for small bowel overgrowth, anything treatable that you can do is helpful. And, there are patients that I have on, things like Creon, pancreatases and, bile acid anything to help with that diarrhea if they have true malabsorption. And, hopefully as you treat them, that gets better too, as the amyloid resorbs. But again, managing somebody who has difficulty taking things, through the enteral route when they have heart failure, it does add complexity, because if somebody just has issues with enteral things, they can't take things enterally, and they don't have heart failure, or they don't have nephrotic syndrome, you give somebody IV this here and there, there are patients that may require TPN. That's really rare. We see that more in the hereditary ATTR space. But that balancing, anything that goes parenteral in somebody who has heart failure is a very special management problem.
Thank you. Faculty here has any other question? No. So I think that was the last question from audience as well. Thank you so much, Dr. Angela. This was wonderful. 2.5 hour session, and you answered everything patiently. And what a great lecture. We are extremely grateful to you on behalf of Mumbai Hematology Group, all my faculty, all the audience. We have over 400 people who have logged in, almost 150 from all over the world, and large number of students. So it's a great service you have done in educating them with your knowledge and experience. Thank you, and have a wonderful day.
hopefully sometime I can come and do it in person.
Yeah, sure. Of course, it will be very soon.
All right.
Thanks to the faculty here. And
Yeah, stay safe.
Yeah, that's right. Stay safe.
Bye-bye.
Bye-bye. Bye. Bye to everybody.
Thank you.